Hello and welcome everyone to the second session of today, which is called Climate Friendly Healthcare. My name is Felicia Matz Wennerhed and I work at Nordic Center for Sustainable Healthcare, and I will moderate this session today. Before we begin, I would just like to go through a few practical details. As a participant in this session, you are free to ask questions to the speakers by writing them in the chat. And if the speaker has time before his or her presentation, she will answer the questions in the chat. But it depends a little bit how much the time allows it. I would also like to remind all of our speakers to keep their microphones off when they are not presenting. So this session will focus on how we can reduce the climate impact of the healthcare sector and how both the private and the public sector can work together and collaborate for a sustainable transition in the healthcare sector. I'm not going to take up more time speaking in this session, but instead hand over the word to our first speaker of today, which is Judith Bree, which is a sustainability consultant from Milieu platform Zorgsector in the Netherlands. Welcome, Judith.
Thank you, Felicia. I will try to share my screen.
Yes, absolutely.
So my name is Judith Bree and I work for Milieu platform Zorgsector in the Netherlands. Freely translated, that is environmental platform for healthcare. We are a branch association for all inpatient and hospital care. Our members come from all corners of the sector, so we have elderly and handicapped care, we have mental health institutions, medical rehabilitation, and of course hospitals. Our goal as association is to create knowledge on sustainable healthcare. So that does not only contain climate-friendly healthcare in the sense that we try to reduce CO2 emissions, but we also look at procurement, scarce resources and circularity, and more environmental topics like toxic wastewater, soil contamination, and biodiversity and the healing environment. In this talk, however, I am going to talk about CO2 emissions, and then specifically emissions from the healthcare real estate. Because in the Netherlands, we have designed a practical approach to reduce emissions from our real estate. This is the real estate roadmap. And I hope to bring you some inspiration if this is something that in your organization is still a huge step to take. And otherwise, I'm very curious if there are suggestions for improving the roadmap or to take into account other factors. Just let me know, we're always open to connect. So I'm going to explain to you how we do things in the Netherlands, and I will walk you through 4 aspects. First, a little bit of context. Like many other countries, we have our own legislation and climate agreement based on the international one. And with the legislation comes a challenge, the real estate climate targets for 2030 and 2050. The bottleneck of that challenge is in some healthcare specific gaps, such as money and knowledge. And of course, I will explain the solution we've come up with the real estate roadmap. So I would like to start with a very brief history of legislation in the Netherlands so that you know the context in which the current events take place. So in 1993, the government already said that all energy saving measures with a payback period of less than 5 years should be taken. Well, unfortunately, the law enforcement on that was really low. So basically everybody got away with doing nothing, especially in the healthcare sector where investments are generally small and ought to pay back in short time. So for a long period, we didn't really do anything. And then in 2012, Europe enforced a piece of legislation on all member states, so the so-called European Energy Efficiency Directive, or EED. I'm sure that some of you have heard of it. And that means that every company or organization with at least 250 FTE had to execute an energy audit and to report about it every 4 years. So the goal of the European EED was to reach at least 20% CO2 reduction by 2020, and this was the start of some more serious action. So in 2013, the government decided on putting some goals down in writing, and this is when the energy agreement was born. We needed to reach at least 40% renewable energy in 2020 by putting down like 1,000 extra windmills. Well, most likely some of you know that the Netherlands are not really on track with that. Currently, we are on a shameful 11 to 12% renewable energy. So it's no wonder that in 2015, several non-governmental organizations stood up and complained. We've had a serious lawsuit against our own government, stating that by ignoring the climate goals, they harmed our own people, and the prosecutors won. So the government woke up and went on to some serious business. And in 2015, those measures with a payback time of 5 years were more clearly defined for different branches. And so the healthcare sector got her own set of recognized measures, as they are called. And that means that all buildings from a certain energy consumption threshold and higher had to take these measures. Then in 2018, after the Paris Agreement, the Netherlands constructed its own national climate agreement called the Het Klimaatakkoord. And we also got a climate law ensuring that the topic would never disappear from the governmental agenda again. So the climate agreement stated 2 clear goals. We have to reduce 49% CO2 reduction in 2030 and 95% in 2050. Those goals were also imposed on the healthcare sector. Well, to make sure that this time something actually happened, law enforcement increased. So healthcare organizations were forced to do the EED audit and report about it to the different environmental events. And in addition, they have to report their progress on the execution of those recognized measures for every location of their organization. In addition, in some branches, for example, offices, there's a mandatory energy label by a set date. So in 2023, they have to, increase one energy label, for example. And this means that in the coming years, they have to invest a lot of money to become more sustainable. Well, the healthcare sector in the Netherlands doesn't have the money to take these far-reaching measures at a natural moment. And by a natural, I mean not during a renovation or replacement of current installations. So this is the reason for another approach, the real estate roadmap. It's an individual plan that shows how to reach the targets of the climate agreement for 2030 and 2050. So rather than a few steps ahead, like an energy label, it shows the whole route to become climate neutral. Secondly, it allows a tailor-made approach, so organizations can decide themselves when to take certain measures and combine them at convenient moments while still achieving the right goals. So with this plan, we try to empower real estate managers themselves to think about the real estate and how to make it more sustainable. And we really try to change the current mindset to a longer-term real estate strategy. But it's also a way to combine a lot of different, now isolated parts of legislation into one big plan, and to avoid unnecessary double administration. And of course, it also shows the sector-wide status quo of the healthcare real estate, and it indicates the future needs in terms of money, space, innovation, and other external factors. So besides the healthcare sector, also the other social real estate branches are working with a roadmap structure, such as education, sport, accommodations, and municipal real estate. And with those roadmaps, we can anticipate on developments in the future, make sure that the gaps are filled. Because currently we don't really know the extent of those gaps. The real estate roadmap shows, for example, the gap in total cost of the energy transition in the healthcare and the current available means. And then the government knows what budgets needs to be cleared. We can also pinpoint where and on what topics gaps exist in the knowledge of the real estate managers, for example, and we can help them more efficiently. We can see if there's a lack of official support or vision from the board of directors, so if there's a support gap. So there's a lot of practical information that comes from a roadmap. So how's this organized? The real estate roadmap is part of the National Green Deal for Healthcare. This means that the government works together with other organizations in a constructive way to solve bottlenecks in the sustainable transitions. And in the Netherlands, we have many different green deals in different branches and on different topics. But the Green Deal for healthcare is mainly between the government, the healthcare organizations, and their branch organizations. So this deal focuses on 4 topics. First, the energy transition. This is also where the real estate roadmap is part of. We have the second topic, circular economy. We have cleaner wastewater and healing environment. So the government asked Milieu platform Zorgsector, independent research organization TNO, and non-governmental consultancy foundation Stimular to navigate the energy transition and the roadmap approach. Together we formed the Expertise Center for Sustainable Healthcare. It's our job to help healthcare organizations with their roadmap and analyze the results. So what do we do to help? Well, first we distribute knowledge on applied techniques such as LED lighting, insulation measures, heat pump application, solar panels, really the practical measures. We analyze individual roadmaps and initiate research where gaps exist. We are, of course, a bridge between individual healthcare organizations and the government and the branches. We're there to answer a lot of questions from real estate managers and other coordinators struggling with their strategy. And of course, we also develop some tools to make it easier and get the healthcare organizations nationwide to just start and make their plan. And one of those tools I would like to tell you about is the CO2 reduction tool. Organizations can use that tool to build their real estate roadmap. And we designed that specifically for care organizations, such as elderly handicapped care, mental medical rehabilitation, so not the hospital kind of organizations. And it mainly focuses on building related energy consumption. And that's also why it's less suitable for hospitals, which of course have a lot more complex process-related energy consumption. And the tool deals well with summarizing many locations, which is often the case in these care organizations, into one dashboard. So it was important to construct a tool that every employee of a healthcare organization could easily handle, especially in the smaller organizations. The real estate manager is often the same person as the purchaser or the facility manager. And that's why we built it in Microsoft Excel and distributed it without user cost. Of course, we made sure that the roadmap that can be constructed with this tool gives dispensation from other legislations, such as the EED audit, and to make sure that the administrative burden is as low as possible. So I would like to give you a very brief insight in what the tool looks like. You can see here a location sheet, and the tool enables you to visualize every location and play with the sustainability measures to see what their impact is on different topics. So what you can see here is a snapshot from the tool. You can see below a list of standard sustainability measures such as insulation and LED lighting, heat pumps, etc. And you can plan them in somewhere between now and 2050. Every measure is attached to a standardized investment and a reduction on electricity and gas consumption. So when you plan them in the graphs on the top, you can see what the measures do with your investment. For example, the first graph, the red and the green light, you can see when the turnover point on the investment is and what happens to the consumption of your electricity and gas, and of course, how the CO2 reduction goes. So of course, it's also possible to abandon or demolish real estate and plan new buildings in the tool. When it comes to real estate strategy, you can see that there are basically 3 choices based on the age and location of buildings. So you have the real estate from roughly before 1990. And in general, you can say that that is not worth keeping unless it has a very valuable location. Renovation of those buildings would mean to almost strip it down to the foundation, and that's very costly. So it's about 60% of the total real estate in the healthcare sector. That's a lot. And then there's the real estate from 1990 to around 2009. That is about 30% of the real estate we have. And with those buildings, the insulation standard is quite okay. This real estate can be kept by doing a life-extending renovation. And then there is the newest real estate from 2009 onward, with good construction standards that can be kept. The buildings can be kept just by upgrading technologies and making sure that all the potential of producing renewable energy is used. So when you assess every one of your locations in the tool, you can see a summary of everything in the dashboard of the tool. And then you can check how you do on 5 topics. You can see that through the graphs in the tool. And of course, you're able to see if you reach the goals of 49% CO2 reduction in 2030 and 95% in 2050. So those are the climate goals. And another question that is answered by the tool is if you can become completely independent from gas consumption. So there's a graph that shows you the electricity and the gas consumption. The gas consumption, we call them the direct CO2 emissions, which are unlike electricity consumption emissions that are caused by you or your organization itself. And in the Netherlands, we depend greatly on natural gas for our heating. We have a lot of gas beneath our soil. But the problem with that, beside the whole climate issue, is that the gas mining is causing earthquakes in the northern parts of the Netherlands. So we really have to get rid of our gas support. And the consequences of that can also be seen in the same graph, because when the gas goes down, you can see that the line of the electricity consumption goes up due to the rise in electric alternatives of gas kettles. And this also points out why we find it so important to not only look at the direct emissions, but also at indirect emissions. So as I said before, the Netherlands is far from completely renewable energy. We really try to stress out the importance of reducing also the electricity demand by measures that save as much energy as possible, and of course produce our own renewable energy. So in the care organizations, not the hospital organizations, we see that the target of 50% CO2 reduction in 2030 and independence from gas consumption is doable. The target of 95% CO2 reduction in 2050 is very hard to reach if you also look at the electricity consumption. Especially for hospitals, it is impossible to produce enough own renewable energy to become energy neutral, since the process-related energy consumption is so high. And it is then our job as expertise center to calculate that gap, communicate that with the government. They can then use this information in the plans for example, our national power grid. So this tool can lay a foundation for your roadmap, and after that there are 2 more important follow-up steps for organizations. That is, first of all, approval by the board of directors, and of course, adoption of the planned measures in the real estate strategy and budget. But we have to take 1 step at a time. So for now, we are busy to support the hundreds of organizations that have started with their roadmaps, and we try to steer them and help them as much as possible. In the coming months, we will start analysis to see if we can draw conclusions from the sector and give this information to the government to fill up the gaps. And that is the end of what I would like to tell you. I will now switch back to the conference software.
Thank you, Judith.
You're welcome.
Perfect. Thank you for that presentation. We actually have to move forward in the program. But in case you would get any questions in the chat, Judith, you're free to write an answer in the chat if you'd like. So with that, I would like to welcome our next speaker, Fiona Adshead. which is the chair for Sustainable Healthcare Coalition in the UK. Hi, Fiona.
Hello, can you hear me fine?
I can hear you fine, and we can see your slides also.
Fantastic, thank you so much. Well, that builds on what Judith was saying about collaborating and building coalitions with the healthcare sector. That's what I want to talk about and what we've done in the UK. Our focus has been not so much real estate, but actually some of the services, so particularly medicines and devices. So who are we? We're a partnership of healthcare companies and other agencies. We were set up initially by the NHS's Sustainable Development Unit. And we bring together both the public and the private sector. And our purpose is really to think about how do we accelerate the journey between not only ensuring good health and well-being for the planet, but also really enabling the healthcare sector to really collaborate as much as possible with the private sector. Why did we get established? Well, once the NHS, National Health Service in the UK, began to look at its carbon footprint, it realised that medicines and devices were actually a large percentage of it, about a third. And so they felt that the only way they were really going to get to the heart of the data and begin to understand and break that down was to work with the sector by sharing experience and data. So the first thing we did was to come up with some carbon footprinting. Very much as you've heard for the real estate sector, we wanted to do this for medicines and devices. And we came up with the first global guidance to do that. But having done that, a lot of the companies in the NHS itself realised, in fact, that that wasn't really going far enough. Because when you think about your own experience of healthcare, when you go to the doctor, you then go to the hospital, there's a whole series of steps. Just as Judith was saying, if you like, there's a roadmap for patients, a care pathway. And what we then went on to do was to break down the different elements of the care pathway, whether it's the consultation with your primary care doctor, through to travel, to the emergency department, each of those sections to come up with a care pathway. What is the guidance? Well, it's freely available. It's available on our website. It really gives people the opportunity to start to think about how do they want to change their services, where are the hot spots where there's the greatest emissions, and what can they do to transform it. So in a way it engenders, if you like, a sense of a circular way of thinking about optimizing existing care pathways, but also at the same time designing new ones and going on a cycle of continuous improvement. We have produced with our members a number of case studies in partnership with the health service to really understand how in reality those products affect the health service and how they can be improved. I'm going to talk about a few of them, particularly use digital methods, but just to say that Baxter have, for example, looked at with kidney patients and renal services about how they can reduce impact by reducing plastics in their devices, but also water flow, for example. And the first case study I wanted to talk about was one that is really at the top of the agenda in the health service at the moment, net zero surgery. How do you begin to get to a surgery that really reduces environmental footprint? And Johnson & Johnson produced a digital support tool to work with their knee replacement to really look at how you can improve outcomes by supporting patients before they had the treatment, during it, and after. And what they showed was that actually by having this personalized digital care program, they were able to reduce the length of stay in hospital, the cost to both the patients in being where they didn't want to be, but also to the environment. And once you extrapolate that to the whole healthcare sector, you can see that it reduces about 70,000 operations, reduce and produce about 4,000 tons of carbon dioxide equivalent. The next care pathway I just want to highlight is around asthma care, where AstraZeneca have developed a smart inhaler, which works with children and their parents to really help them again understand how they can best improve their care on a daily basis, allow children to control their asthma, and then to reduce the number of times, again, children need to go into hospital. It actually reduced exacerbations and got a greater control of the disease. And what that shows that really greenhouse gases reduced by about 50% because of the improved patient care. And I think both of these examples really show us just how important it is to think about the carbon footprint of the device itself, but also how you use it in the healthcare system. So this has made us think, particularly with all the impact that COVID-19 has had, about just how important digital solutions are. They really can play a critical role around the triple bottom line of not only improving patient outcomes and reducing costs, but also reducing environmental impact. And what we believe, just as Judith was reflecting, that it's absolutely critical to be able to measure this so that you can improve and realize the potential benefits that are actually there. But you can't do that if you don't measure it. So we've also worked with a digital platform provider, Patients Know Best, to look at what they're doing by providing digital care records to patients to improve the carbon footprint, again, for services. Here, the support is for patients with severe dermatological conditions. They've actually used their platform to enable clinicians to track patients' condition using both consultations and questionnaires to the patients themselves. And what they found by taking this approach is that you can avoid about 75% of outpatients' attendances, which has had a huge saving, about 20 kilograms of carbon dioxide per patient. Again, it's a way of making health services more efficient, improving patient outcomes, but also reducing environmental impact. Because we really want this approach to be used as widely as possible, we've now launched a digital pathway calculator, which allows people to really question what they're doing with their care pathway, a what-if scenario. You can access it online, you can put in data, you can begin to work out, at least at a high level, what your footprint might be and how you might change it when you're looking after patients. We don't just focus on the care pathway approach. We've been looking across a broad range of areas. How you can apply circular economy principles to healthcare, not only through improvement, but actually through care pathways. We've particularly been focusing on supply chains and procurement because there are huge opportunities there. One of the challenges is that healthcare organisations don't often procure based on environmental impact. And if they did, what we know is that actually it would lead to more innovation in the sector, and it would enable us to not only measure, but to reduce environmental impact. So it's important that the market has that information so it can change. Plastics has become a huge issue, as you're all aware, and we've been looking at complete priority category life cycle assessments, looking, for example, at IV giving sets to really look at how, what the plastic impact is, but also how we could reduce it. We're continuing to develop our guidelines and care pathways. We're currently working with a hospital in the north of England looking at renal care pathways, and we've also been looking at Boehringer Ingheim's reusable inhaler. At the heart of this, though, I think that what we've realised is that if we can work together to test and learn, to really think around how the healthcare sector can improve, work closely with its manufacturers and providers and collaborate, that we really can lead to positive change. And so as a coalition, we really welcome opportunities to collaborate, understand barriers to change, and test and learn new approaches, because what we've learned from practice and some of the case studies that I've presented is that that can lead to real change. So that was all I wanted to say. We really welcome the opportunity to talk, engage, and learn from others, because that's, I think, what's really going to move this agenda forward. So thank you very much for the opportunity to talk about our collaboration.
Thank you very much, Fiona, for that presentation.
Thank you.
Thank you. So the same information to you. If you would receive a question in the chat, feel free to write We actually have a question now. I can read it to
Yeah.
you. Wonderful to see the online care pathway calculator. There has been a lot of debate on the carbon footprint of online activities. Is the calculator applicable for use in other countries?
Yes, it is. Our calculator has actually been developed working both in the UK, but actually in America as well. So some of our case studies have actually been based on international healthcare examples. I think one of the issues about care pathway calculators or any of this methodology is that it's not about absolutes. What it's there to, absolute measurements, what it's there to do is give you an example and a sense of where the biggest impact will be. So it's good at looking at hotspots, it's good at giving you relative measures. What we would encourage people to do if they really want to go into detail is to do a much more detailed life cycle analysis, like, for example, we're doing with the NHS up in the northeast of England. But it's a good way of at least beginning to get to grips with where you need to focus, and then it enables people to go on and do things in more detail if appropriate.
Great, thank you. Thank you very much for that answer. So if we don't have any more questions for Fiona, I believe we will move forward in the program.
Thank you so much.
Thank you, Fiona. So our next speaker is Poul Bunde from Region Zealand in Denmark. Welcome, Poul.
Thank you. Hello, my name is Poul and I'm working with sustainability in the region of Zealand. In Denmark, we have 5 regions established in 2007. And in the region of Zealand, we have more than 800,000 citizens, 17 municipalities, 635,000 buildings spread over 7 hospitals, 5 psychiatric institutions, 8 social institutions, and 2 administration buildings. 80% of the energy consumption goes to the hospitals. Sustainability is not a new thing. We have worked with it in many years. We have worked in 2 tracks: sustainable operation of buildings and sustainable buildings. In sustainable operation of buildings, we have worked with energy managing, energy measurement, energy saving, conversion to renewable energy. We measure the amount of energy consumption for each of our buildings. We measure electricity, heating, and drinking water. We have data from since 2009. The low-hanging fruit is taken long ago, but we have managed to decrease the consumption of heat and to stabilize the consumption of electricity. At the same time, the activities at the hospitals have increased. We have mostly worked with energy saving. In 2009, we established a local pool of money from which the local building users could apply for a loan to complete an energy saving project. The loan had to be paid back by the savings. The pool consisted of 10 million kroner per year, nearly 1.3 million euros. In 2010, the region went together with the municipalities and applied the EU for a part of the ELENA project. ELENA is the European Local Energy Assistance. It's a big project. EU could contribute to the counseling, but not to the energy saving project itself. Our project we called REES, Renewable Energy and Energy Efficiency in Zealand. 5 years later, we completed the project after an investment more than 70 million kroner, 9.4 million euros. A part of the project was established of solar panels on the roofs on several hospitals and institutions. In 2015, the solar panels produced more than 1 million kilowatt-hour electricity. It was less than expected, but still good. We also have an energy partnership with an electricity company called CSNVE, and during the partnership they help with behavioral campaigns, energy screening and other projects. After the Rees-Elena project, we started to look into the ESCO idea. ESCO can be done in many ways. We decided to get it financed by leasing and not by the ESCO company. And to start, we made an EU tender for finding ESCO companies to analyze the possibilities for energy-saving projects on a number of hospitals. It resulted in 2 sub-agreements with Siemens for 3 hospitals and Kemper Lauritsen for 4 hospitals. It is good to have 1 or 2 specialists analyzing all the buildings because you get an analysis based on the same basis. After the analysis phase, we negotiated about which project we wanted to be completed. And last year, the construction phase started. One of the reasons why we choose ESCO is that we get a possibility to combine projects with different payback times. We wanted a payback time at 15 years in the projects from the ESCO companies, and with a leasing payback time in 20 years, we got space for a little more expenses. The other track, sustainable buildings, we work with, we require sustainability in our building projects. In 2009, we made a model for screening every project for energy and sustainability. It is best if it is done by another consultant than the one who had done the design of the project. And for the greater projects, we have certification. In 2012, we tried to screen after the DGNB, Deutsche Gesellschaft für nachhaltiges Bauen, and later the politicians have decided that projects to more than 100 million kroner, 13.4 million euros, has to be certified after this model. That's how we have done. Thank you.
Thank you, Paul. Thanks for that presentation. There seems to be no question as of now. If there would be some further on, you're free to write an answer in the chat, Paul, if you would like. Thank you. So I think we will proceed with the program. Our next speaker is Jens Peter Nielsen, who works at the University Hospital Koege in Denmark. Welcome, Jens.
Thank you very much. Just a moment, please. Yes, my name is, as you said, Jens Peter Nielsen. I'm proud to be here. I'm a chief project manager at the University Hospital Koege. And my education and experience from the last 25 years is I'm a construction engineer. I have been working with sustainability in all kind of areas like renewable energy, sustainable buildings, etc. But now I will start my presentation and we'll try to split screen. Just a moment, please.
No problem.
I will start with a short introduction about our project in general, and then I will go to the DGNB as a tool in creating sustainable hospitals buildings. Now what you see on the screen is the existing hospital. Nowadays it doesn't look like that. Already we have start up a lot of our building sites, so you shall imagine that there's a lot of holes and concrete working going on, but this is what we start with. In the right bottom, you can see 2 buildings separate from the hospital, and these buildings are going to be demolished in the future, but before that we have to erect some new buildings where we can move the patient and equipment to. This is the plan for the new hospital, what it's going to look like in the future, and our investment in the building is about 590 million euros for the building side, and 118 million euros for equipment. And because we are using the low energy class in the newest Danish building legislation, we have the possibility to make an effort in the energy saving area where we can invest more than 12 million euros. Now you see the new building approximately will be about 145,000 square meters, and the existing where after we have demolished the 2 buildings you saw before will going to be about 50,000 square meters. And in the building we will have 789 single bedrooms, 38 intensive care rooms, operation theaters, and surgical rooms is about 41, and our therapy for radiology, etc., will include a lot of scanners, 5 and 47. Here you see an illustration where we can see the different kind of building tenders and turnkey contractors we are going to erect in the future. We have the TE01. It is going to be the bed wards and treatment area. It's going to be about 110,000 square meters. We have this laboratory and nuclear medicine building, TO2A. We have a sterile central, T2B. We have an energy supply center where we can make the cooling, and we have the possibility to adapt the emergency power, TO3. We have a rebuilding of an existing building where we haven't going to have the goods reception and the pharma unit. We have already erected TO5, which is an office and conference building. We are going to establish a diabetes research center and the medical education in TE06. And then we have the remodeling of the existing B7. This is the main schedule for the project. We expect to be finished with the new buildings in the beginning of 2025. Afterwards, we have to do the remodeling of the existing hospital. So we have a lot to do. It's a very exciting project, and we of course have the aim to establish buildings as sustainable as possible inside a very strict budget. The DGNB certification, as Poul said before, is a strategy in the region of Zealand, and as we see it, it is a process to where you can make this holistic view of the project and the building must be sustainable in terms of environmental, economical, and social aspects. The DGNB is administered by Green Building Council Denmark, and we have already one certified building at the moment, and I will get back to that. Here you have an overview of the DGNB criteria. There's environmental quality, economical quality, social, cultural, and functional quality, technical quality, and process quality. And besides that, you also have to review the site quality. This you might call a DGNB wheel. It shows all the criteria you have to go through before you can get the certification. And the aim, of course, is to fill out the circle total with colors, but in some areas you might have some difficulties to do that. It is important for me to say that, as I said before, the process, this extra quality review regarding sustainability is the goal, not the medal, where you can reach either silver, gold, or platinum. And all these different kind of medals and criteria you can see in details on the dbnc.dk homepage. As I said before, we have this administered from Green Building Council, and they have all the important information and documents on their website. Now, we have to compare the DGNB with other priorities in the project. And as I said before, we are using in our tender the demand of erecting buildings according to the newest Danish building regulation, low energy class, and also a very highly focused, prioritized aim in commissioning. Therefore, we can also focus on other aspects in the DGNB. Example of that is durability and maintenance of building materials, the patient safety, example, visual comfort, and also, of course, quality in the outside areas, because when you are a patient, you might need to get out of the hospital for rest, and it is important that you have small gardens, small paths, ponds, and so on in the outside areas. Now I'm only referring to the buildings, but some might say, what about the healthcare or hospital equipment? This is not handled in the DGNB criteria, but of course we are focused on this issue, and we try in our tenders to have some demands in the efficiency of medical equipment, etc. In our tenders for the turnkey contractors, we try to ensure the most possible sustainability, and therefore we have a lot of descriptions about our demands in building materials, building installations, etc. And we have established a lot of design manuals. Design manuals we can use in the tender. The first step is a building for office and conference facilities, and we have reached GMB Gold. It is about 4,200 square meters. And at the moment, we are using this building for our organization, the project team. There is some medical education inside, and also our main turnkey contractor is in the building. Here you can see an illustration, but the actual thing is it's very similar to this. Yeah, I think it's about that, and you can of course ask me a lot of questions. You can contact me afterwards also if you have any questions about our project.
Thank you for that, Jens. Thank you. So we're gonna wait for some questions coming in the chat, a couple of minutes. I can see that we actually have a question that was asked to Poul Bunde. So if Poul would like to unmute himself, I can read the question to you and you can answer. Hi, Poul.
Hi.
The question you got is, what is your experience with environmental certification?
Our experience with it is, as Jens just told us, it's a process tool, and it is a very good tool. We will continue here in the region with using it for the great projects. It's very positive.
So we are still gonna wait for some questions from participants. We got a comment from a participant, this G and B circle looks good. It gives some freedom in where the actions have priority for your organization. Towards Jens. My question is also about the DG and B certification. It now seems that every country puts a lot of energy and effort in developing certification tools. So the initiative from this conference already pays off, but how do we integrate them?
In my opinion, you have to make an active decision, and you have to, as Poul said before, maybe it is the recommendation is to make the decision as high as possible in an organization. And if you can get the backup from the political system like Region Zealand, I think it is the next step is how can you include the DGMB in your building projects. And of course, you have to make some. You have to use some of your budget to this certification, but if you, as we do, have it already included in the tenders when we make our turnkey tender, I think it is possible to make a good process in collaboration with the turnkey contractor and other parties involved. So it is about good planning and active decision, I think.
Okay, I can see that we have just a quick follow-up question on that. Following the earlier question you just answered, Jens, must this be an EU initiative?
That's a good question. I think my experience with is mostly with the DGNB. There's a lot of other certification system. You have the BREEAM, you have the LEED, and so on. So of course it could be a good idea to focus on that in the EU, because at the moment a lot of these EU's legislation that we are trying to involved in the Danish, for instance, legislation is often about energy savings. But I think when you have these new low energy classes, etc., you might focus on other areas, like I said before, how is the building experience for the public? How are the visual comfort? How are all these kind of things involved in new buildings? Because I think sustainability is other things than energy savings and materials. It is also all these social aspects and so on. So
Yeah, thank you for that. We have 2 more questions for you, Jens. The first one is, as the Danish energy mix becomes more renewable, the CO2 footprint of the construction phase becomes more important. How do you work with that issue in your coming projects?
Now we focus on our project and try to do it as sustainable as possible within the budget. And of course, we are aware of the carbon footprint, etc. But we also have to erect buildings that's safe, buildings who have long life terms and so on. So we are using often also material that has long life, availability, and also low maintenance. So we also use traditional building products in our project, and some of them might have some big or carbon footprints, etc. So it is hard to say that we don't. Yeah, I think that might be the main story.
Okay, thank you, Jens. One last question for you. How is patient safety included in the DGNB?
There's a lot of things about patient safety. It's not just one criteria. It is involved in a lot of criteria. It is how can you feel safe about when you're walking in the house, how is the fire escape, how is the change of air in the ventilation system, etc. There's a lot of different kind of patient safeties that is involved in the several of criteria in this DGNB model.
Okay, thank you. There was one more question that came up here. It's the last one I'm going to ask you. Possibly I missed it, but does the D, G, and B certification include CO2 reduction. So does the CO2 reduce to 0 when the certification circle is at 100%?
No, it doesn't reduce it to 0 CO2. But as I said before, a lot of these, when you have the building in the future, a lot of these different kind of installation and ventilation plants, cooling plants, etc., they have a very low energy use, and in that matter, you can say you have a low use of energy. But of course, in all the building materials, you have this CO2 thing. So you can't say it's a 0-2 building, 0-2-0 building.
Okay. Thank you for that, Jens. We are going to move forward in the program. So our next speaker is Lars Nielsen from Siemens. He is presenting from here today, from DTU. So I'm going to share his presentation from my screen. Hi, Lars.
Hi. Thank you.
Welcome, Lars.
Yeah, my name is Lars Nielsen, and I'm working at Siemens, and I'm a director of a department in Siemens who work with energy efficiency in public and private sector. I will tell you a little bit about a project we have done in the capital region in Zealand, and it's Hvidovre Hospital. It's an old hospital from the 70s, and you can see on my slide the 4 buildings, but it's not only the 4 buildings, it's also the green area you can see besides it where people are treated. It's a hospital around 240,000 square meters, so quite a big one, and there are coming 90,000 patients there yearly, so it's quite a big hospital. And this model is what you also heard about Region Sjælland. In Denmark we call it ESCO, but in European terms it normally called energy performance contracting, and it's very much supported by the EU. And it's a self-finance model, so it will not, you say the hospital or the region will not have any money to use on it. When we started talking with Hvidovre Hospital, they already had a plan for the coming years. They had a plan that in 5 years they want to be a sustainable hospital, and they also want to have 10% of the hospital consumption to be covered by renewable energy. And they also have a goal to reduce the consumption with around 15%. So it's very nice to have a customer here that has already, when we start talking to them, goals for what they want. And this energy efficiency model, as I said, is a self-financing model. And if you look at this model, you can see on the left side, you have the cost of energy on the Y, and you have on the X the time. And before we started, they used around 63 million Danish kroner on energy. It's around 8 million euros. And during the period, we will save them 16 million kroner yearly, around 2 million euros. And after, you could say, the project has been paid back, they have this yearly savings on 16 millions. So during a short payback time on 10 years, we had reduced the energy consumption with 16 million. So seeing for the budget from the capital region, they have used today 63 million, and for the next 3 years, they use the same 63 millions, but they will have upgraded the hospital with a lot of new functionality and reduced the CO2 heavily. This model is increasing also the speed and also the scope of the green transition here. Normally, when we talk to public customers, they have been working with climate change and energy savings for a lot of years, and they normally use this stepwise implementation on energy efficiency. So typically it would take 15 or 20 years for them to reach a reasonable level of energy consumption. But here we can do it on 2 or 3 years. And you can see on my screen here, the climate win is that they will save energy very much quicker than over the 2 years instead of 15. So if you calculate it over 15 years, you have more or less the double of energy savings if we are doing it quickly and if they had done it by themselves. And we also see in these projects extra savings because we are looking on all the energy consumption in the buildings, and we have in Hvidovre Hospital we use 5,000 energy engineers to go through the hospital. So we find solution that also combining heating, cooling, and so on. And in Hvidovre we have upgraded all their cooling system. So in the past they have an efficiency on the cooling system on 3, and now they have it around 10 to 12 in efficiency. And that's the reason is that we are using all the heating that the cooling machines are producing on the ventilation, so we can come up in a better efficiency. And we also buying a lot of stuff on this project at one time, so there's also economical of scale that we are buying and can get better prices when doing it at once. One of the things that the hospital very much want to have was this solar panels, and we have installed solar panels all over the hospitals, so that we don't have a roof on the hospital that doesn't have solar panels if it was possible. So it's, I would say, the biggest one in the Nordic countries, around 2 megawatt. So it's very, very big and has produced for 2 or 3 years now. We have also installed 15,000 new LED, and you can see on the left side where the old one, and you can see on the right on the new one, and it's very obvious to see that it's not only the light that's getting better, but also the temperature, and on the right side is more, what you say, well-being. It's more nice to be in the environment with a more white color. The hospital director asked us if we have painted the walls, but it's only the lighting that does that. And we have also worked on a better environment for the patients. There has been a big project with renovating the bed rooms, and here you can see a patient lying, and there's you say he can, on this screen, he can adjust the temperature, he can adjust the lighting level now, he can also adjust the blinds, and he can order food, he can look at television, he can go on the internet. So all that will give a better environment also for the patients, and also the ventilation are more accurate, regulated now. So if there's more people in the rooms, it's turning up, and if people are not using the room, it's shutting down. So it's more efficiency, but it's also better for the patient when they are in the rooms. So if you say what these ESCO or energy performance contracting is doing is, you can reduce the CO2 reduction with 20 to 40% in a few years. In Hvidovre, it's around 33%. We have reduced the CO2 reduction. And the good thing is that they are self-financed, so the project is paid by the energy savings. And in these projects, there's also the limited risk for the hospital because it's a private partner as we are that guarantees the energy savings. So if we are not reaching the energy guarantee savings, we have to pay back to the hospital. So they are sure of, you would say, the business case. It also gives better indoor climate, and that's also giving the patient have to be there a shorter period, and the persons or the staff is less sick, and we also see from that it also will increase the productivity if you have a better indoor climate. So also, as you would say, not energy benefits here that is very good. when we have a hospital from the 70s, there has also been a very big maintenance backlog on the technical infrastructure. And these projects will also upgrade a lot of the technical equipment and will maintain the value of the building. And the good thing is that it's all based on proven technology, so you don't have to invent anything. You have to use what are on the market today, and you can, of course, start immediately. I heard from the previous question that someone said, yeah, okay, the energy will be more and more green, and that's also true, but in Denmark we have a climate council that said that energy efficiency is the cheapest way to do CO2 reduction. So it's a very good thing to reduce energy in buildings. I also told a little bit earlier that the EU is also much supporting this model, and in 2017 we won a European Energy Service Award for Hvidovre Hospital, and that's of course was very nice appreciation to what the capital region has started here. And we were also so lucky that we had the energy minister from the Danish government visit the hospital to see it, and we also have the chairman for the capital region also visiting at the same time. And I have a little short video here showing a little bit about the hospital, and unfortunately it's in Danish, but there's English subtitles, so see if it works. Yeah, okay.
Continue.
I can hear you. You couldn't see the screen, but if you get my slides afterwards, there is a link to YouTube where you can see the whole video. It's only 2 minutes, so.
Perfect.
Yeah.
Thank you very much, Lars. Let's see.
Any question?
Okay.
Yeah, we had a question here saying that payback time depends heavily on energy cost and loan margins for investment. What was the basic situation in your calculation? Yeah, we had decided together with the capital region that we had, you could say, frozen the energy costs from the start. So we are not guaranteed, you would say, the energy prices, but if we are not fulfilling our contract, we will use the energy prices from the start. Regarding to investment margins, at least the loan or the leasing that the capital region has, you would say, funded the project with is a government institution, so I think the margin is very low. I think the loan is 0 point something. Yeah, I don't think there's any more questions at the moment.
Okay. Yeah.
Yeah.
Well, then we thank you very much, Lars. Thank you. Great. So with that, we are going to conclude this session. Lars was the last presenter. I want to remind everyone that we are recording the sessions, so if you would like to see them after the conference, that is possible. And we also have the PowerPoints available from the speakers. We're going to end this session a little bit earlier. We are now going into a bit of a longer lunch break, so I will see you in the afternoon in our next session. Thank you very much.
Thank you.